It's wonderful that you are here on a Sunday morning at 8:30. It's almost pathological to be here, but okay. So we are very happy that you are here. So a very warm welcome from the whole faculty and from BI. Okay, I'm going to present you. I don't have nothing on my screen. It's there, yeah. Thank you. I'm going to present now immediately our speakers. And as you can see, it's very balanced. You might think, yeah, there is 4 psychiatrists and 1 person with a lived experience. That sounds very unbalanced, but I'm going to reassure you it's very balanced because, as you can see, it's gender neutral. We have 2 female speakers, 2 male speakers. There's 2 American speakers, 2 European speakers. And for the American ones, 1 from the East Coast and 1 from the West Coast, so it's pretty balanced, I think. So let me first start with Lara, because she's going to be the last speaker. Lara Shirikjan, she's from California, coming over from California, so it's in the middle of the night at the moment. And she's a psychiatrist. Yeah, it's 4 psychiatrists, as I already said. Working for Cinexcel CNS and very much involved in putting up and doing clinical trials. Then we have Dr. Sara Costi, and she's from the University of Oxford, and she feels very much at home here because she was born and raised in Italy, in Parma, before going to the US and now being in Oxford. And for those not familiar with it, I can strongly recommend, she's one of the driving forces behind the Ketamine Journal Club, which is usually on a Tuesday evening, so highly recommended, where they invite people just publishing on these issues, on ketamine and everything around it, and having very nice discussions, and she's really one of the drivers of that. And then, of course, we have some people don't need any introduction, and that's exactly the case, of course, for Michael Thase, from Philadelphia, University of Pennsylvania. And it's good to see here that last minute he changed his picture, because this picture looks a little bit like he looks now. Because before, he had a picture which is almost like mine. You see mine there, you know, this is about 30 years ago. And to be honest, Michael and myself, first time we met is 30 years ago. So we're getting old man. And 30 years ago, and it's always a pleasure, Michael, to spend some time with you during the many occasions we had in symposia and ad boards, etc. Okay, this is the speakers, and let's now move forward. It should start. But it's Sunday morning. No. Ja.
Mein Name ist Falk Schuster und vor allen Dingen bin ich Papa und glücklich verheirateter Mann. Bin Papa von 3 Kindern und darüber hinaus bin ich von meinem Ursprungsberuf Schauspieler und Sprecher. Den Beruf habe ich aber mittlerweile an den Nagel gehängt. Und ich arbeite mittlerweile als Coach hauptsächlich für Menschen, die jetzt vom Jobcenter oder Arbeitsamt kommen und neue berufliche Wege oder überhaupt wieder den Weg ins Arbeitsleben suchen, und berate darüber hinaus auch Forschungsprojekte, Unternehmen wie Boehringer Ingelheim in Studien und genau. Und auch einzelne Menschen zu unterschiedlichsten Themen rund um die psychische Gesundheit. Also ich habe eine schwere Depression gehabt. Ich denke nicht mehr, dass sie schwer ist. Ich bin auch nicht ganz sicher, ob ich jetzt noch depressiv bin in dem Sinne. Ich nehme aber nach wie vor Antidepressiva in einer geringen Dosis, um stabil zu sein. Und begonnen hat es bei mir im Alter von 15, würde ich sagen, 15, 16, dass ich sehr starke Schlafstörungen hatte, auch, wie sagt man, psychosomatische Symptome wie Magenkrämpfe und so, wofür keine physische Ursache gefunden wurde. Und zu den Schlafstörungen gesellten sich dann im Teenageralter auch so anfängliche Suizidgedanken. Also nicht in der Richtung dass ich überlegt habe, wie ich mein Leben beende, aber dass ich das Leben einfach nicht mehr lebenswert fand und überlegt habe, ob es nicht besser wäre, einfach, dass es vorbei ist. Und leider habe ich mich damit niemandem anvertraut und dadurch eine lange Reise begonnen, die sich hauptsächlich darum drehte, das möglichst zu verbergen und die mich viel Kraft gekostet hat, mich vielen Schwierigkeiten gebracht hat, bis ich dann letztlich, ich sage aus heutiger Sicht, Gott sei Dank, im Jahr 2012 das nicht mehr verbergen konnte. Da war ich arbeitslos geworden und einfach konnte mein tägliches Leben nicht mehr, also überhaupt nicht mehr auf die Reihe kriegen und hatte immer mehr Schwierigkeiten, sehr viele körperliche Symptome wie ein Tinnitus, Magenschleimhautentzündung, Konzentrationsschwierigkeiten, Orientierungsschwierigkeiten entwickelt.
Okay, this was the introduction. He will come back in between the different presentations. So I have the pleasure to give the introduction. Here are my disclosures. So if we talk about depression, about major depression, of course, everybody knows the criteria. It's not the audience where I have to explain this. The strange thing is, however, if we say, yeah, there should be depressed mood, number one, or anhedonia, number two, these are mandatory. But if you say there should be depressed mood, negative mood, but nothing is said about the absence of positive mood. And you might think that positive mood and negative mood are highly negatively correlated, but that is just not the case. So it's a bit strange that it's absent in the definition. So anhedonia is the second one, is considered a core symptom of depression, and I'll come back a little bit on that. The problem with this definition of depression, we have these 9 DSM criteria. This makes that, in fact, a depressed population, of a population of depressed patients, is very heterogeneous. The heterogeneity is a huge problem. It's probably one of the reasons why we can't well differentiate between different drugs with different modes of action and different outcomes, because we mix up, we lump everything together into one depressed patient population. Because if you base on the 9 DSM symptoms, you can already have 227 unique profiles. And if you cut increased or decreased sleep, which is not exactly the same, or increased or decreased appetite, or psychomotor retardation or agitation, not exactly the same. If you cut that down, you end up even with 945 different profiles. And all of them can enter randomized clinical trials for a new treatment. And the question is even, if I take it a little bit further, a little bit more provocative, is this sufficient, these 9 DSM symptoms, or are there even many more symptoms in depression? I like very much this study. Most of the studies were performed by Eiko Fried. What Eiko did here was looking, and it's kind of network analysis, where you try to investigate the interactions between the different symptoms. And you even try to go for which is now the most central, the central node, the symptom that is most strongly connected with all the other ones. What you see here, look at with me at the left part of the slide first. This is the quits symptoms. And the quits symptoms, the short version of the IDS, this is just reflecting the DSM symptoms. Okay, you see there a note, I won't go into detail. You see these are connected, there is connections between all these symptoms. Then what Eiko did is, at the right part of the slide, he took the IDS. So also the symptoms that are not in the DSM. I give you an example, because the patient will talk about that, or talked about that, the somatic complaints, for example, or the gastrointestinal problems. They are not in the DSM definition of depression. And he put them also in the network. And if it is true that only the DSM symptoms are important and the other are different, well, the network analysis should give you 2 clouds. And as you can see here, it's not just one cloud. They mix up with all the other symptoms, they are entangled, and it's just one entire thing. So this suggests that, okay, we have our 9 DSM symptoms, but maybe that's not enough. There's many more symptoms that are important in depression. I already said that there is nothing in the DSM definition about lack of positive mood. And despite the fact that lack of positive mood is probably the most specific depressive symptom. With specific, I mean, I'm not saying the most important, with specific, I mean the one that differentiates best the depressed mood state from other psychopathological conditions. This is here a very beautiful study, I feel, from Olsen. They used the CESD, the Center for Epidemiological Studies Depression questionnaire. The good thing about that questionnaire is there is 20 items, 16 about negative mood and 4 about positive mood. They constructed 2 subscales, the one with negative mood and with positive mood. And then they have a patient population with psychopathological dimensions of somatic complaints, anxiety, depression, mania, paranoia, schizophrenia, blah, blah, blah. If you look at the correlations for these specific dimensions, and you look at the correlations for depressed affect, well, you see almost all of them, somatic complaints, anxiety, depression, mania, paranoia, schizophrenia, borderline, they all have about the same degree of correlation. We all know somebody with borderline personality problems will also have negative mood. That's not necessarily depression. But if you look at the positive affect, you see there's only 2 that are correlated, and that's depression and mania. So apparently, if you look at this, it suggests indeed that positive affect is probably something most closely linked, most specific for depressive and manic mood states. This is something about the diagnosis. Of course, we all know depression is a huge burden on the person itself who suffers from depression, on the significant others around that person, and it's also a huge problem in our society. It is even influencing longevity. We all know that people suffering from depression, their life expectancy is much lower than people not suffering from depression, and it's even more pronounced in men than it is in women, as you can see here. It's about 10 years difference. And of course you might think, yeah, this is probably due to excess mortality due to suicide. No, suicide is only the minor part of it. It's mainly about somatic comorbidities. And some have to do with the pathophysiology of depression, and some have to do with behavior linked to depression. So it is important because, specifically for man, the longevity is reduced. It is also important from an economical point of view, as you all know. You see here the claims in the UK, the claims for mood disorders, claims for sickness and disability. And you see, among the psychiatric disorders, the most important contributor of it is mood disorders. You might think we consider sometimes anxiety disorders, mood disorders, personality disorders as the common mental disorders, and then we're going to say, yeah, schizophrenia, etc., that's the more severe mental disorders. But the impact economically is much larger for depression because the prevalence is much higher. And then we go to treatment. And you attend this symposia here, this symposium and other symposia during ECMP, and you're going to see quite a lot of graphs and showing outcome with different drugs, etc., in patient populations. Well, the question is, of course, what is the ecological validity of all these studies that are shown and which are the basis for everything which is so-called evidence-based? If you would, next week, see a first time a patient suffering from depression, what is the chance that that patient can be enrolled in a randomized clinical trial? Well, it's somewhere in between 10 to 20%. 80 to 90% of the patients will be excluded because they don't fulfill the inclusion criteria or because they fulfill the exclusion criteria. 3 examples here, one of ours, the FINDER study and the STAR-D study. So everything we say, we show, everything in guidelines is based on randomized clinical trials, and that is valid for 10 to 20% of your patients. I did not say invalid for the other ones, but we just don't have enough data there. Going back to antidepressants, the heterogeneity, as I said already, the heterogeneity of patients suffering from depression, but there's also the heterogeneity of the antidepressant marketing. Are we going towards personalized medicine, that the more specific psychological profile of a patient will predict outcome? For those in the audience being a little bit older, like Michael and me, for example, well, you see here the history of antidepressants. It all started, let's say, from the newer antidepressants, I'm going to say. In the 80s, we had the SSRIs, and they went for comorbid anxiety. Duloxetine came somatic symptoms. Agomelatine came lack of positive affect and hedonia. Cognitive functioning, vortioxetine. So there has been, from marketing points of view, putting the light on some associated symptoms. Some may be more central, some probably more peripheral. But nowadays, we no longer only look at symptoms. We want to look at functioning, quality of life, the meaningfulness of life, which is most important for patients, and onset of action. What scales do we use? Well, standard is still the Hamilton and the Montgomery-Åsberg. Remember, I said anhedonia is a core criterion in the definition of depression, but if you look in these scales, there is almost nothing on anhedonia. In the Hamilton, just one score out of the 7, on one score on one item out of the 17. In the Montgomery-Åsberg, 2 out of the 10. And in the Beck, you see it's more cognitive behavioral. There's a kind of conflicts of interest with these scales, because the Hamilton Depression Rating Scale reflected what tricyclic antidepressants are do. A lot of anti-anxiety, sleep-inducing, weight gain, etc. Montgomery-Åsberg, that is the 10 items from the CPRS that changed most, that improved most, while taking a variety of antidepressants with different modes of action. And the Beck Depression Inventory, many of the items there are cognitive behavioral because, of course, it reflects what cognitive behavior therapy can do. And then you think PHQ-9 reflects, mirrors the DSM criteria, so that's going to be a good scale. And again, I'm not so sure, because if you look, is this so specific for depression? I think, again, a very interesting study here is looking what the authors did here is taking patients with different diagnostic labels, depression, PTSD, schizophrenia, etc. And they gave them, all of them, they were administered the PHQ-9. And then they looked the score on the PHQ-9 with a correlation with the WHO-DAS. And you see the correlations are all in the same range. And then they looked, these patients were treated the way they should be treated, the patient with schizophrenia with an antipsychotic, depression with an antidepressant. And they said, yeah, response is 50% decrease on the PHQ. And what do you see? Well, it's not that different in the different diagnostic categories. You have about the same percentage of responders on the PHQ-9, which is so-called specific for depression, but probably is not. Coming to the end. Moreover, these scales do not reflect what patients expect from treatment. This is a study, one of ours, and you see here the 10 most important, the highest, the ranking of the 10 most important issues for patients out of more than 50 items. And you see here that 7 out of the 10 have to do with positive mental health. Look at Mark Zimmerman's papers, it's exactly the same. That's why I think we should reconsider the definitions we use, in the standard Kupfer and Frank terminology, remission and recovery. Recovery is long-standing remission, but since Sarah is here with Italian, so recovery comes from ricoverare in Italian or in Latin, and that means getting back the positive, while remission is fading away of the negative. And fortunately, psychiatrists are supposed to be a bit more precise in their phrasing and their wording, but unfortunately, they often are not. And this is then my summary. Given the heterogeneity of depression, treatments that are appropriately tailored to a patient's specific presentation and can work across symptom clusters are really needed. Large-scale trials and real-world evidence are needed, both needed, that are more representative of the patients living with MDD seeking help. And co-developing new treatments with patients is crucial to understand their needs and identify novel mechanisms for more effective depression treatments. Thank you for your attention. Let's now listen again to Fox's experience of living with MDD.
Also mit einer der größten Auswirkungen hat definitiv die Schlafstörungen. Sie sind jetzt für sich genommen pro Nacht ging es irgendwie, aber der Effekt, dieser schleichende Effekt auf die Dauer von zu wenig Schlaf war einfach unglaublich. Auch Konzentrationsstörungen. Und einer der größten Schwierigkeiten, mit denen ich zu tun hatte, waren Entscheidungsschwierigkeiten. ich war irgendwann nicht mehr in der Lage, selber Entscheidungen zu treffen, weil ich jede Entscheidung mit inneren Vorwürfen, Dialogen auseinandergepflückt habe. Also es gab so ein ganz exemplarisches Beispiel, dass ich in den Supermarkt gehen wollte, mir eine Gurke kaufen. Und im Supermarkt mir Vorwürfe gemacht habe, was für ein Idiot wäre, was ich jetzt mit dieser Gurke will. Ich wollte doch zu Hause kochen. Und wieder nach Hause gegangen bin und zu Hause gesagt habe, sag mal, bist du zu blöd, eine Gurke zu kaufen? Also die fand ich unheimlich quälend, weil die irgendwann dazu führten, dass egal welche Entscheidung ich fällte, sich alles für mich nach der falschen Entscheidung anfühlte. Das war so quälend und zermürbend und natürlich on top Suizidgedanken sind, das wünsche ich niemandem.
So it's nice to be back. I think my last DCNP may have been 2018 in person. I don't have hemianopsia. I will try not to ignore this part of the room, but as you can see, we're biased towards the right up here. I'm Michael Thase. I'll be talking from a clinician's perspective on our unmet needs, the treatment of depression. We are almost 10 minutes behind already, and I apologize. We did rehearse, but we've got some audio delay issues here. Here are my conflicts of interest. These are not to be minimized or trivialized. You will notice that even when I go to bed at home at night, I must face conflicts of interest. So when we think about the pathway for a person to develop a major depressive episode, we think that it's complex and multi-stage. And there are 2 points of interest on average, or entry on average, early in life and then at midlife. And these obviously reflect different potential risk factors and also influence what kinds of symptoms you're more likely to experience in your depressive episode. I think importantly, whether you get diagnosed or not is not always a given. At any given time in the United States, about 40% of people who meet criteria for an episode of depression aren't in any treatment whatsoever. Some of them have not even had to come to professional attention when they're picked up in epidemiologic studies. And then whether you get treatment or not depends on who you see and who you sought for treatment, whether you see a psychotherapist or whether you see a physician who's prescribing, and then whether that practitioner follows guidelines or not in how they implement the treatment and how they monitor the outcome and how they make changes in the treatment. I think importantly, we're all aiming, both the person receiving the treatment and the person providing the treatment, we're aiming for our patient to get better to the point that they are not ill any longer. And by convention, we've used the term remission to describe the virtual absence of that illness, and then recovery to describe being in a state of remission for a good number of months. I think importantly, once you've had an episode of depression, you remain at high risk for a recurrent illness. And it's at least 50 to 60% with the first lifetime episode, but after 2, the lifetime risk goes up to over 70%, and after 3 episodes, without preventive treatment, you may have an 80% risk within the next 3 years. And so some have referred to this as a kindled process. It certainly is an internally destabilizing process, and a lifetime management plan really becomes necessary for those with more highly recurrent episodes of depression. So there are lots of things that get in the way of getting this recovery. I think importantly, in many care settings, the prescriber may initiate a prescription but then lose track of the patient's progress with that particular treatment. And in one of the care settings I work at the VA, the average is about 3 to 6 months between the initiation of the initial treatment and the decision that it's not working and to move on to another treatment. This is really, really concerning because you can identify who's not likely to benefit from a treatment pretty easily within the first 2 weeks. If there's no improvement whatsoever, we need to make a change. It doesn't have to be a change in treatment. It could be an up titration for some medicines. But the difference between 2 weeks and 6 months for an ineffective treatment really can have serious negative effects on the quality of an individual's life, that person's performance in the workplace, and of course his or her relationships as a parent, as an intimate partner, as a friend. I think importantly, if you do not have an effective treatment and you do not work a plan in order to continue on that effective treatment, then your chances to actually recover from the depressive episode are pretty significantly diminished. So from the patient's end, we still have stigma, even though things are much better than they were 30 years ago. And stigma can be at the level of society, at the level of an individual and his or her friends and family, or even at the level the individual internalizes it. I think you heard from Falk some issues with his own stigma about whether or not he should obtain treatment or receive treatment. You know, it's not really human nature to follow a doctor's advice, particularly when the advice is the daily ingestion of medication that may have some significant side effects. And in the United States, there's about a 10% chance a medicine doesn't get filled, and about a 20 to 30% chance that first prescription doesn't get refilled. So this means 40% of the patients aren't going to have the chance to benefit from that intended treatment, at least for that initial episode. And of course, folks who don't adhere to medication are less likely to get better. The act of actually adhering to a treatment increases your chances of benefiting both directly and indirectly. And I think then there's also access to care, and this is true both in the EU as well as in the United States. Substantial minorities of people say that it's not available, or the kind of treatment they want is not available, or when they try to seek psychotherapy, they can't find a psychotherapist to see them, can't afford the medicine the doctor has recommended, and so forth. So I think we've got a lot of hurdles that prevent us from implementing the treatments that we would like to work. So do we follow guidelines or not follow guidelines? You know, the guideline movement crested in about between 2000 and 2010. We're at a point in which we're sort of ambivalent about the guidelines we have. Sometimes the guidelines get caught up in politics. The American Psychiatric Association guideline has been fearful of conflicts with industry. We don't have a new guideline from the APA since 2010. Sometimes guidelines get caught up in economic and cost-containing concerns. For those friends here from the UK, I'll just point to the NICE guidelines and the kind of deprioritization of more expensive treatments and leave it at that. So the guidelines don't always dictate what kind of treatments that you get. Both guidelines, APA, NICE, even the EPA guidelines do include the role of psychotherapy, but psychotherapy has its own implementation and dissemination difficulties. I think importantly, at least psychiatrists have a belief that moderate to severe depression is best treated with antidepressants, not psychotherapy. The evidence suggests that the boundaries of severity that should inhibit the use of psychotherapy are quite high, and the vast majority of depressed outpatients can be treated nicely by capable psychotherapists. But can you find a capable psychotherapist, and does that capable psychotherapist actually do an evidence-based medication? I think sometimes our patients think, I don't want to engage in psychotherapy because it might be too upsetting. We almost never have a patient drop out of an evidence-based psychotherapy because it's been too upsetting. That's another example of how stigma might impact the treatment. I've mentioned the limitations of the number of psychotherapists available. This is true EU, UK, United States, all over the place. And in the short run, an evidence-based psychotherapy is costlier than treatment by a general practitioner with a generically available antidepressant, although those costs tend to balance out across the first year and actually may favor the psychotherapy when patients are able to stay well past that first year. And then sometimes you just can't find a good match between the patient and the therapist or the type of therapy. And we see some people who do better with interpersonal or dynamic therapy than cognitive behavior therapy and so forth. So one unpleasant experience with psychotherapy is probably no more informative than one unpleasant experience with an antidepressant medication. So speaking of antidepressant medication, this is that timeline that you all have seen, except I've truncated it to begin at 1985, which is when the newer generation of antidepressants began. Please notice this is obsolete term. 1985 is 40 years ago. And so the newer generation is old. But then look what happens. We get the first SNRI in 1993. The curse sort of remains dead for the next 30 years because we've had improved versions of medicines that target monoamine uptake, monoamine receptors and so forth. But we've had no true trailblazing treatments come out until we get to 2019. Wait a second. Oh, I went backwards. I'm sorry. So, what we learned in STAR-D, massive study, nearly 3,000 patients began, is that when we use these monoamine targeted treatments, most of the patient's chance for benefit happens in the first 6 months of care. And so you have a fairly good chance with your first or second try. Not as good as advertised, but still a fairly good chance. But by the time you get to the third line of treatment, the chance of success diminishes pretty substantially. And by the time you get to the fourth line of treatment, you have less than a 15% chance, basically, of remitting with that treatment. So as the probability of remission decreases, the growth curve, if you will, about the probability of recovery flattens off. And had there been a fifth treatment tried in STAR-D, a fifth medication treatment, maybe we would have expected a 5% chance. We're approaching asymptote when we stay with 5 treatments targeting monoamine systems. So we've got real unmet needs in the state of pharmacotherapy, the treatment of depression. Our antidepressant efficacy is modest. The placebo expectancy and the care that we provide accounts for a majority of the benefit for a given patient's episode of treatment, and that placebo expectancy and care factor carries most of its weight in those first 6 months of treatment. The monoamine targeted treatments are slow to work, and you may see hints of benefit in the first couple of weeks. I mentioned you can tell when non-response is coming, but you can't predict who's actually going to remit so easily in the first 2 weeks of treatment. There are some patients that just can't tolerate these newer antidepressants, these 40-year-old newer antidepressants. And then, of course, as we've talked about in STAR-D and in our practices, about 1 in 3 people who begin treatment will not respond to our available first and second line medications, these so-called difficult to treat or treatment-resistant depressed patients. And although the second generation of antidepressants certainly were safer in overdose, more tolerable on a day-to-day basis, they have some side effects that particular patients find most disagreeable, including sexual side effects, some risk for insomnia, not especially good for anxiety and cognition, and so forth. So pharma knew we needed different antidepressants 20, 25 years ago, and there were lots of potential targets for these newer generation, a third generation, if you will, of antidepressants. But one after another, after another, after another of these interesting evidence-based targets failed to bring forward new, truly paradigm-changing antidepressant medication. And I use a shipwreck metaphor here. Each time one of these antidepressants failed, the major pharmaceutical company that was invested in developing this often made the decision to leave the area of studying novel antidepressants. I won't name names here, but some of you were involved in some of these projects, and you know what happened to your employer's motivation to find new antidepressants when a $100 million program went belly up. So then came 2000, the serendipitous discovery of the antidepressant effects of ketamine, and by 2019, the first new glutamate-targeted antidepressants received regulatory approval in the United States. Some of these reserved for more difficult-to-treat patients, S-ketamine, following the stereoisomer of ketamine being an example for that. Others being targeted for novel populations, so brexanolone for postpartum depression. And these agents differed not only in their target, but also in the onset of benefit. These medicines have a faster onset of benefit than the antidepressants that preceded them. And so we went from shipwreck after shipwreck to a sense of optimism that there may well indeed be novel targets that actually lead to effective treatments that can help some patients that weren't helped by the medications that came before them. So I think we have a significant public health problem, an illness that is prone to chronicity with a relapsing or recurrent course, with a strong need for those with more highly recurrent illness to have lifelong or at least indefinitely planned treatment alliances in place. And with all this in mind, we have needed better treatments for the 1/3 of patients who haven't found the benefit from our second generation of antidepressant medication. So I think we are on the precipice of having a true next generation, and hopefully in the remaining portion of our talks today, you'll see some evidence that even other targets are just around the corner for us. So let's go ahead and hear from Falk, and I will try not to botch this. One more click, right? I think patience is one of the operative variables here, although our time clock keeps running.
Also das eine hatte ich vorhin gesagt, also dass unser Gehirn veränderbar ist. Sicherlich können wir nicht alles komplett rumdrehen, aber es ist beeinflussbar. Neue Synapsen können sich bilden, um sozusagen im Gehirn, salopp gesagt, andere Wege zu gehen. Und das andere, was ich gelernt habe, was ich unbedingt teilen möchte, ist, dass Depression ist eine Erkrankung. Viele Betroffene, ich würde sagen, von allen psychischen Erkrankungen kämpfen auch viel mit dem Gefühl von Schuld oder Selbstvorwürfen, so nach dem Motto, naja, Person XY hat doch vielleicht vergleichbare Umstände, aber eben keine Depression entwickelt. Also muss es doch an mir liegen. Und zu realisieren, dass es eben eine Krankheit ist, die enorm unsere kognitiven Fähigkeiten beeinflusst und damit auch unsere Fähigkeit, Auswege zu finden. Das ist, finde ich, ganz wichtig zu verstehen, weil ich habe mir auch lange Zeit Vorwürfe gemacht, Mensch, dann überleg dir doch was. Dann überleg doch, was du machst, was du tun kannst. Und dass das Teil der Erkrankung ist, dass das Betroffene, vor allen Dingen, wenn es eine sehr schwere Depression ist, kaum noch können, irgendeine positive Vision oder positive Auswege zu finden. Das finde ich extrem wichtig zu verstehen, dass es keine Schwäche ist, sondern Teil der Erkrankung. Und dass es auch der Hauptgrund für mich ist, warum Betroffene professionelle Hilfe brauchen. Weil diese Wege da raus allein kaum zu bewältigen sind, wenn es um eine schwere Depression geht. Bei einer leichten ist das sicherlich was anderes. Aber je schwerer sie ist, umso schwieriger wird es da allein rauszufinden. Und das zu verstehen, finde ich sehr wichtig.
So thanks to Boehringer Ingelheim for inviting me back to the ECNP.
Abgesehen von all den Symptomen und Sachen, die eine Depression begleiten können, die ich schon beschrieben habe, ist vor allen Dingen auch diese innere Auseinandersetzung für mich immer wieder ein Thema, zu akzeptieren, dass es mein Weg ist. Dass die Depression Teil meines Lebens ist. Weil ich glaube, das ist zutiefst menschlich, sich auch immer mal wieder an die Frage zu kommen, ja, warum habe ich denn das jetzt? Was soll das jetzt? Und irgendwie zu akzeptieren, das hilft nicht weiter. Es ist, wie es ist. Und das ist meine Aufgabe. Und jeder hat irgendwo eine Aufgabe, sei es vielleicht keine Depression, aber ein anderes Thema. Und das, mich dem anzunähern und zu sagen, ja, das gehört eben zu mir. Und damit sich lernen umzugehen, das war eine große Herausforderung für mich und die ist irgendwann sehr ins Positive gekippt, weil ich dann irgendwann gemerkt habe, es ist einerseits eine Herausforderung, aber sie bringt so viel Schönes auch in mein Leben, weil ich dadurch so viel lerne. Ich meine, ohne meine Depression säßen wir ja heute nicht hier zum Beispiel. Ohne meine Depression hätte ich gar nicht die Chance, zu so vielen Menschen über psychische Gesundheit zu sprechen und denen Mut zuzusprechen, denen Hoffnung zu geben, dass Sachen sich ändern können.
Okay, I don't want to interrupt Falk again. So, thanks to Boehringer Ingelheim for inviting me back to the CNP. I hope this is not my last one. I wish you a great conference, and we'll see you a little later for Q&A. We'll see Falk towards the end if we have the time to do that. So thank you very much.
Okay. Well, thank you, Boehringer, for having me. This is just before we start my disclosure, nothing really related to the talk today, but if you have any questions, please feel free to come later and we can talk more about that. So I think after these talks, it takes me a little convincing that depression accounts for one of the greatest disability worldwide, definitely in the context of mental health. It accounts for 50 million years lost to disability, so it's an incredibly burden for our patients and their family. It is associated with increased mortality. It also gets along with an increased suicidality, especially in younger people. And as Professor Thase pointed out, 1 in 3 patients do not respond to conventional antidepressants. And it's not only that they don't respond, but we have to wait usually at least 2 weeks to see if an antidepressant is working before switching to another one. So, of course, the length of time keeps increasing while our patients are feeling rather unwell. So it comes with no surprise that the first report of rapid antidepressant effect of the NMDA receptor antagonist ketamine represented a major paradigm shift in the field. This work comes from the first trial on ketamine. We are approaching 25 years ago, and they show that a single subanesthetic dose of ketamine at 0.5 milligram per kilogram administered continuously over the course of 40 minutes intravenously was able to induce a rapid, meaning within hours, and peaked at 24 hours, and sustain that lasted few days, so beyond what is the half-life of the drug, antidepressant effect. And this is then being replicated in several trials and multiple meta-analyses. And so don't take it just from my words, but these are basically from John Crystal, who was the senior author on that 2000 paper, and I quote, "To the amazement of their patient and themselves, they found that ketamine produced a rapid, profound, and surprisingly durable antidepressant effect that were temporarily dissociated from the brief acute behavioral effect of the drug." So it really stands out that ketamine probably works in a completely different way compared to the conventional antidepressants. So in order to think about it, let's take a step back and see what happens when in the neurosynaptic level when we have a depression. So as you can see on the left, there is a schematic representation of a glutamatergic synapses at the level of the prefrontal cortex. And there is a nice balance of activity between GABAergic interneuron and glutamatergic synapses that ensure that there is glutamate at the level of the synaptic cleft and glutamate recycling, so that this leads to a whole series of protein synthesis at the postsynaptic level and release of neurotrophic factor. But what we see in condition of depression or chronic stress, inflammation, HPA axis dysregulation, I mean, you name it, is that we have an increased activity of the GABAergic interneuron that has a consequence, is associated with a decrease in glutamate at the level of the synaptic cleft, reduced cycling of the glutamate, and a reduction at the level of protein synthesis as a downstream, and reduced release of neurotropic factors like BDNF. So we know that ketamine effects involve the opioid system, other system, the monoaminergic one as well. But in order to explain ketamine rapid and sustained antidepressant effect, we know that its main effect is at the level of the NMDA receptor, and it's mostly an effect of antagonism. It doesn't happen only at the level of the prefrontal cortex, but involves also other regions of the brain, like, for example, the lateral habenula, and I'm going to talk about this in a moment. But if we go back at the slides that we were looking before, this is how we think that ketamine is an effect. So here you see the NMDA receptor at the level of the GABAergic interneuron. The antagonism of ketamine is able to, again, increase the level of glutamate at the level of the synaptic cleft. This increase the cycling of the glutamate presynaptically, and this has a downstream effect postsynaptically through the mPAR receptor that increase protein synthesis, synaptic spine formation, and the release of neurotrophic factors. And altogether, this is, we think, responsible for both the rapid and the prolonged antidepressant effect of ketamine. However, it becomes also very interesting, how does this translate at the neurocognitive level and then downstream clinically? So as I mentioned before, there is some evidence that this effect at the level of the NMDA receptor by ketamine affects specific area of the brain. One of the one I mentioned was the lateral habenula. So the lateral habenula, the habenula in general, is a very small area of the brain, deep in the brain, and is also known as the center of loss. So depression is, per definition, a condition associated with loss. But we also, there's been several data in imaging studies showing that we have in depression an increased activity of the habenula, and is usually seen as a counteralter to reward centers like the striatum or the VTA, the ventral tegmental area. And what they have shown in animal data is that systemic or the local administration of ketamine was able to reduce the burst of the habenula in an animal model of depression and reverse the depressive phenotype. So basically the animal was not depressed anymore, or at least not showing any behavioral characteristic of depression. NMDA receptors are also very important in the process of memory consolidation, reconciliation, and memory retrieval. And there has been work done by Emma Robinson lab that showed that ketamine affects this process of memory reconsolidation or retrieval in a way that if there is information that is encoded previously to the administration of the drug, that's the one that is affected by ketamine administration. So it's very different from what we see with conventional antidepressant. This seems to affect the information that is encoded after the after the administration, not the one that is encoded previous to the drug administration. So, as a researcher, we got very interested to see, is this the case also in humans? Can we translate these findings in a human sample? So through an experimental medicine trial, we tried to translate this animal research. We enrolled 70 healthy volunteers. We randomized them to either ketamine or placebo in a 1-on-1 fashion. And then they completed a series of tasks, emotional processing tasks. And they also completed a 7 Tesla MRI scan at 24 hours. Then they come back 1 week later and they were exited from the study. So I really want to bring your attention on the emotional processing task and on the 7 Tesla scan. I'm going to describe this very quickly to you. So one of these was trying to replicate these findings from animal studies where they were, the animal was acquiring information previous and after the drug administration. And so we asked our participant to encode a list of positive and negative self-describing adjectives prior to the infusion. And then we asked them to recall them 24 hours later, and we were interested to see if there was any difference between our ketamine or placebo group. So there was really not a difference in terms of words that were correctly recalled in the ketamine or in the placebo group, but we saw a difference in the proportion of positive and negative words that were falsely recalled. So basically, the ketamine group tended to think a bit better or a bit less worse about themselves, just not about words that they were previously encoded. And our participant also completed a facial expression recognition task after the drug administration, and then they repeated it at 24 hours. So immediately after the administration of the drug, there was no difference between the two groups. There was a small difference at 24 hours in the sense that the ketamine group was slightly more accurate and a bit faster in responding compared to the placebo group. At 24 hours, they also completed a 7 Tesla scan. And we use a 7 Tesla because the habenula is a very small, deep in the brain region. And in order to engage the habenula, especially because these are healthy volunteers, we used an fMRI paradigm that was developed to prompt the habenula and has been studied in clinical population. This task is a Pavlovian conditioning task. So our participant will lie in the 7 Tesla scan. They will see a series of symbols, and the different symbols were associated with the different outcomes. So you would have symbol associated with reward, symbol associated with loss, symbol associated with neutral, and symbol associated with electric shock. It was a small pain in the hand. We weren't that mean. And we were mostly interested in the shock because that has been shown to be the most aversive stimuli. So what we observed is that there was not really a difference between the ketamine and the placebo group at the moment of the stimulus presentation. But when the two groups differ was at the moment of the delivery, where we see that the ketamine group was associated with an attenuated habenula bursting, habenula activity, compared to the placebo group, especially in the first run of the task. So just to summarize this data from these experimental medicine trials, this was completed on healthy volunteers, and we noticed that ketamine induced a positive memory bias for self-describing words. It didn't really show an immediate effect on facial expression recognition task. It was probably associated with pro-cognitive effect at 24 hours. And I think we were able to show that ketamine attenuate the habenula response to aversive shock stimuli. So why is it important that we think of ketamine mechanism of action? Not only because it's completely different from conventional antidepressants, but because as a clinician, mostly, we really face the challenge that is, on one side, the need to help our patients to feel better and feel better sooner. But also, we are also dealing with the limitation of using ketamine. Like, for example, we don't have long-term safety data. The data that we have available comes mostly for small sample size trials. Ketamine is a controlled substance, so there is a potential for abuse. And also, we have information that comes mostly from ketamine abuser, for example, the risk for cystitis and even for brain atrophy. This has not been reported in population that use ketamine for antidepressant, but it still remains as a warning because people that abuse ketamine has been shown this kind of lesion in the brain and at the level of the bladder. And again, these are the 5 studies that led to the esketamine approval. And I just want to point your attention. The sample size is definitely bigger compared to the trial that have used, that have studied ketamine. I think the largest one on ketamine is the ECT versus ketamine one that was recently completed in the States. But if we look at the duration, the first 3 transform that just have a duration of 4 weeks. So in terms of safety data, we're looking at just 1 month, and then the sustain are a bit longer, but still is still overall a limited amount of time. And just because we are on the topic of esketamine, I think we are all pretty familiar with the indication of esketamine use, both in the US and in Europe. And this is just to say that it's not a drug that is available to everyone, but is really tailored for a specific set of patients. So there are definitely challenges associated with the use of ketamine and esketamine. They are associated with acute side effects like dissociation, visual distortion, and sedation. There is a risk for potential side effects. We mentioned before the bladder, the brain atrophy. Esketamine can be administered only through REMS, so certified medical facilities. They're both controlled substances. And last but not least, ketamine is not approved for the treatment of major depressive disorder and is used off labels. So there is still despite this great paradigm shift in the field, there's still unmet needs for rapid acting treatment that are better tolerated and even more accessible. So just to very quickly summarize, depression is one of the most common and disabling conditioning worldwide. Ketamine and esketamine are NMDA receptor antagonists that has a rapid and sustained antidepressant effect. Ketamine induces a positive memory bias, attenuates the abenular response to aversive stimuli, and possibly exhibit a procognitive effect 24 hours after its administration. But there are still a lot of challenges with ketamine and esketamine that goes from abuse risk, dissociative side effects, administrative burden. So there is still a large need for rapid acting treatment that are better tolerated and more accessible. So I just want to introduce the next speaker and just in the meantime say a big, big thank you to my collaborator at the University of Oxford and over at Mount Sinai and to all of you today. Thank you.
Hello. So what does all this mean, right? We have some great information here. I'm going to kind of try to bring it full circle so we can go over it. These are my disclosures. So Dr. Costi very eloquently described the mechanism of action of what's been going on, what it looks like with ketamine. I'm going to go into it a little bit more here, a little bit differently, with focus on the NR2B NMDA receptors. So these are primarily located in the brain regions and circuits that are associated with cognitive functions and consciousness. And so I want to just take a step back and talk about glutamate for a second. We've been focusing on glutamate, and you're going to be hearing it more and more at these types of conferences. Glutamate is the hot topic, not just in major depressive disorder, but in other areas such as schizophrenia, Alzheimer's, because of the components of multiple areas that we're targeting: cognition, memory, mood regulation, right? These are all really important things that we need to tackle for our patients. So what is the role in all this with glutamate? Well, when we look at the brain, the last, Dr. Thase went over since, 40 years now, we've been pretty much looking at the monoamine story. We've been looking at serotonin and dopamine. Why are we not focusing on glutamate? Serotonin and dopamine is like 1% of the neurons in the brain. Glutamate is about 40%. So why have we not been focusing on this? Why are we ignoring it? So this is why the focus is on glutamate right now. We're taking a look at what we can do, what we can work with. All of these mechanisms, actions that we've been covering today are proposed, but we're learning more and more as we go. It's conferences such as this. So it's really exciting to see that we're focusing on a different thing. And now focusing on this NR2B subunit, we know that there's regulation with synaptic plasticity. That is something else that's different. When I was in training, in the recent past, we didn't think that we had neuroplasticity, right? We think, after you're 25, that's it. It's dead, it's dead. But now we can look at the brain and say, okay, we can have some growth. We're looking at BDNF, we're looking at different mechanisms of actions that Dr. Corti covered, and we're seeing that there is plasticity and availability there. Studies show that the NR2B subunit is crucial for a wide range of memory functions and its expressions, which have cognitive capabilities. Now, again, Dr. Costi covered this, but the proposed mechanism of action here is as follows, and we're going to kind of simplify it in a step-by-step basis. So the NR2B NAMs decrease GABA release from the GABAergic neurons. The decreased GABAergic interneural activity results in that increased glutamate release, and thus the synaptic BDNF release that we need for the neuroplasticity. BDNF triggers a chain reaction, activating those proteins, the mTORs, which are needed for the synaptic plasticity and the synthesis of new proteins. And then the increases in the synaptic protein lead to increased synaptogenesis. And thus, the series of events cause for areas of growth in areas of the brain that we need to focus on for things like memory and cognition. So, what does all this mean, right? We talked about ketamine and esketamine, and now we're talking about the NR2B NAMs. So, they are somewhat doing the same thing, but a little different. Ketamine and esketamine, as we've been learning, they're non-competitive receptor antagonists. So they're basically turning off the receptor, preventing its activation and downstream signaling pathways. It's a blockade. It's blocking the ion flux, and it results in a decrease or inhibition of the receptor's activity. But because of this abrupt decrease or stop, we're having kind of more intense side effects. These are the ones that we're learning more about: the dissociation, respiratory depression, sedation. Those are things we're not used to in our typical antidepressants because obviously this mechanism of action is different. So like, we've discussed, you've got a REM center, you've got treatment facilities that can only dispense these medications because it's controlled. They're controlled 3 substances. They need regulation for dissociation of at least 2 hours. So the side effects have been warranted severe enough that need extra caution other than just prescribing the medication to your patient and sending them on their way. The proposed mechanism here with the NR2B NAMs, because they are allosteric modulators, they are binding to the allosteric sites on the receptor, causing a conformational change, not a blockade. So this is reducing the ion flux, but not blocking it. And thus, we are proposing that this has a more tolerable side effect profile. And as we know, a medication is only effective if the patient actually takes it. So if a side effect profile is high, it may deter a patient from taking the medication, which is why we need more options for our patients. And so this is a kind of a cartoon version of what we talked about. And I like to think of it, when we're studying in school, we're thinking, how are we going to remember all of these things? All these images pop in your head. Well, I like to think of this as a nightclub, as the discotheque many of you probably attended last night, or probably not attended, okay? So if you look at this club, you've got on the far left, you've got your regular club. People are coming in and out. There's a nice balance because you don't want your club to be too empty, but then you don't want it packed, right? You want a nice balance of good-looking people at this club, okay? That's the normal ion flow. And then if you go to the far right, that's the party where ketamine comes in. Ketamine's the police, is the fire marshal. And they're shutting it down, this party, because it got too wild in there. It's packed. The glutamate levels are all over the place. Something's gone awry. So ketamine came and shut it down. So now you've got a blocked channel. This is how I remembered it. With the NR2B NAMs, it's more of having a bouncer there, right? They want there to be a nice flow, good-looking group of people in there. They're going to kick out the rowdy guys. They're going to let in a couple of cute girls. They're trying to create balance by reducing the ion flow, okay? They're the bouncer of the club. They're regulating it, but they're not completely shutting it down. And this is how I like to think of it. We want there to be a balance because the whole concept of glutamate is you don't want too much and you don't want too little. It has its place. It has its purpose. So next time you're at the club, just think that you're in a big pool of glutamate and you'll have a great time. So now the BI compound, 156992, and that's the last time I will say that number. It's going to pop up a few times. This compound is an NR2B NAM that is being explored in 2 different phase 2 clinical trials in patients with MDD. One is adjunctive, meaning the patient is taking an antidepressant, and the second is monotherapy. The adjunctive has been enrolling since the beginning of this year, around March, all across the world, US, ex-US, everywhere. The phase 2 is US and Japan only, and it's rolling out right now. The first site just got activated. So in the adjunctive study, which is currently enrolling, it's a 6-week, multi-center, randomized, double-blind, placebo-controlled, dose-finding trial in patients with major depressive disorder with inadequate response to ongoing antidepressant treatment. And the monotherapy, again, is monotherapy, again, double-blinded, 6 weeks, multi-center, randomized, placebo-controlled dose-finding trial in patients with MDD. So for the adjunctive phase 2 trial, just like we would with any trial, right, because I do clinical research, we have a screening window. We make sure the patient's eligible. We do labs, safety, make sure that they're the right fit for the study. This one's unique in that we have the optional 6-week lead-in, because again, we want patients to be on an antidepressant. So if we needed to have them on the right dose, stable dose, there was a 6-week lead-in. After the screening period, at day 1, which is baseline, once we've determined that they're eligible, we have 4 arms. We have high dose, medium dose, low dose, and placebo. All are taken in conjunction with an SSRI or SNRI. Those patients are going to take this over the course of 6 weeks. And again, the arms are 2-to-1, 1-to-2 ratio with the order listed above. We're looking at the primary endpoint in this study in the MADRS score day change by day 8. So that's pretty quick, right? But that's our assumption based on what we've been talking about today, is that this should work quick. This shouldn't take 6 to 8 to 10 weeks, if at all, because this is a different mechanism of action of what we're used to with our typical antidepressants. So in those first weeks, in the first 8 days, we're looking at the change in MADRS as our primary. And then again, we have, just as any study, a follow-up period to close out any adverse events or anything like that. The inclusion criteria was ages 18 to 65, patients with an established diagnosis of MDD, which we confirmed with the MINI, which is very commonly used for clinical research. We looked at a current depressive episode of 8 weeks or more, and we looked at the HDRS severity score of 17 or more. And again, we were looking for patients with insufficient treatment response, meaning they had 50% or less response into 4 or less antidepressants in the current episode. And again, primary outcome was that MADRS change, but we had secondary outcomes, including definitions of remission and response, which we'll go over, and different scores in different depression scales. So the monotherapy is a little bit different. Again, they do not have to be an adjunctive oral antidepressant. This can be monotherapy. That's why we're looking at patients who could also be on their first episode. They didn't have to have a recurrent episode because they didn't need to be on medication. And again, we're looking at patients with 0 to 1 antidepressants during the same episode. Primary endpoints, again, safety, tolerability, and MADRS. For this one, the MADRS was at the 6-week mark. We also assessed for dissociation using the VAS scale, which again, for all studies in this category, that's standard to check for dissociation, as well as patient-reported outcomes. We looked at other endpoints, again, different scales assessing for depression. So in this one, again, we had a screening window. We had the treatment arm, 2-to-1 to 1-to-2, high dose, medium dose, low dose, and placebo. We looked at this again over the course of 6 weeks and had a follow-up visit. Now, we don't have the information yet. We're looking at summarizing all this in the early 2026, which is not that far away, but these are all the things that are currently in progress with research. So just to summarize what we covered today, the NR2B and MD receptors are located in brain regions crucial for cognition, memory, mood regulation. That makes them a promising target for the development of novel therapies for the treatment of major depressive disorder. Ketamine, esketamine, and the NR2B NAMs are NMD receptor modulators that work through distinct mechanisms and have different safety profiles. The NRB2 NAMs represent a potential antidepressant that offers rapid and sustained relief with a more tolerable side effect profile. And the BI compound, which is the NR2B NAM, is enrolling studies for 2 different phase 2 trials, adjunctive and monotherapy. Thank you. We'll hear from Falk again.
Ich finde, dass mehr Menschen verstehen sollten, dass bestimmte Folgen von einer Depression, wie, sagen wir mal, der Klassiker, man kommt nicht mehr aus dem Bett oder so, keine Frage ist von einer persönlichen Entscheidung, sondern von einer fehlenden Fähigkeit. Ich habe es wirklich auch erlebt in der Klinik, dass ich morgens nicht aus eigener Kraft ausstehen konnte. Nicht, weil keine Muskeln da sind, um das zu bewerkstelligen. Das Gehirn schafft das nicht mehr. Das wissen Wissenschaftler besser, warum das ist, aber und das zu verstehen, weil es gibt ja oft diese gut gemeinten Ratschläge, ja, Ratschläge sind ja auch eine Art von Schlag letztlich. Mensch, mach doch mal wieder Sport oder geh doch mal wieder in die frische Luft, geh spazieren und ja, und dass das eben, versuche dann immer Menschen zu vermitteln, wenn das so einfach wäre für die Betroffenen, würden sie es doch tun. Ist ja niemand, der gerne eine Depression hat. Der sagt, ach, das ist doch schön hier, jetzt kann ich mal schön im Bett liegen. Deswegen, wenn sie es wirklich könnten, würden sie es tun. Und das finde ich, das sollten alle Menschen oder sollte man gleich in der Schule schon beibringen, dass es eben bei der Depression oder vor allen Dingen auch bei psychischen Erkrankungen generell Menschen das nicht mehr schaffen, das allein zu entscheiden, sondern es einfach schlicht dann nicht mehr können. Ohne fremde Hilfe. Ja, mein Wunsch ist es, dass ich irgendwann als Opa da sitze und zu einer Welt beigetragen habe, wo meine Kinder und meine Enkel, falls sie psychische Schwierigkeiten haben, dass sie einfach keine Angst haben, sich Hilfe zu holen und darüber zu reden. Oder die müssen ja nicht unbedingt zu mir kommen, sondern dass sie einfach keine Scheu haben, nach Hilfe zu fragen. Ja, das ist mein absolut, ja, wenn ich das mal erreicht habe irgendwann, dann wäre es cool. Zumindest beigetragen, ja, dass ich dazu beigetragen habe.
So I think we are well on time, so thanks to all the speakers for being on time. So that means that we have about 15 minutes of Q&A. So for those still having questions, please send them via the app so that we can try to give a decent response on it. Okay, I have a few questions already. Maybe we can start here. Let me have a look. A very small one to Sarah. Did you also measure any effect on reward functions in the ketamine study?
Sorry, any effect on reward?
Reward.
Yes. So, well, the task itself also had a component on reward. It was looking at reward stimuli. We are analyzing that data now. And then we had clinical scale looking at anhedonia and pleasure scores that we are looking at.
Okay. Another question to you is you elegantly showed us the difference of ketamine influencing the recall of negative and positive adjectives.
Yeah.
But apparently in face recognition that was not very convincing. How can we interpret these findings? Do you have an idea why it is more effective on this recall than on recognition of faces?
Well, a way of looking at this is that the word encoding, right, they were presented these words prior to the infusion, and then they were asked to retrieve it 24 hours later. So this was information that was acquired prior to the drug administration, while the facial expression was showed to them after the drug administration and then again at 24 hours. So a way of looking at this is really a translation from the animal findings, where ketamine seems to be impacting information that was previously acquired and not novel information. And in this way, it's quite different from conventional antidepressant. I think on animal studies, they did the similar work using fluoxetine.
Could it also be that one reason would be that, if I remember well, these were all healthy volunteers?
They're also healthy.
That maybe the final answer on my question will only be there when you will have the data in depressed patients.
We're still recruiting for that, so hopefully soon.
Okay. Maybe something for, I don't know, Sarah, Lara, whatever. From your experience, is there a difference in the long-term safety or safety issues of ketamine and esketamine?
It's a question for me. Well, again, I think we have more data on esketamine. We have more data in terms of longer-term data from clinical trials on esketamine. We don't have many on ketamine. I think the data that we have for ketamine not only comes from small trials, but also for trials that were like short, quite brief, like short in duration. There is some information that is coming mostly from clinic that are based, I would say, mostly in the United States or in Canada, that it seems to be generally safe. But, I'm afraid the time will tell.
There's differences like with ketamine, more of interstitial cystitis or urinary tract infections with long-term use, different side effects like that.
Not for the ketamine that he's used clinically. This report that comes from clinic in the US and in Canada using ketamine for depression did not show any increased incidence in cystitis. It is something that happens with people who abuse of ketamine, but the amount of ketamine they're exposed to is dramatically different. So when we use ketamine, clinically is at the 0.5 milligram per kilogram. Sometimes it's a bit higher because it can be modulated. But when you have people who abuse of ketamine, we're talking about grams each day. So it's quite a different level of exposure, and it seems to be a toxicity that is dose-related.
A question for Michael. The patient mentions at a certain point that he is still taking a small dose of an antidepressant. Does this make sense? And more generally, how long should we treat our patients with a conventional antidepressants? And do you think that could be different with the new agents that we have now?
So generally, the dose of antidepressant that you took to get better is likely to be the dose that you should remain on to prevent relapse and recurrence. And the one possible exception to this rule was with fluoxetine. With its long time to steady state, we often prescribe perhaps higher doses than might have been necessary had we been more patient. Fluoxetine is the one modern antidepressant that lower dose has shown a similar relapse prevention to higher dose. I hope that Falk's stigma caused him to want to present to us that he only needed a small dose of antidepressant and that he was taking the correct dose of antidepressant. So for most SSRIs, several of the SNRIs, you don't have strong dose-response relationships. And so whether it was a smaller dose or a higher dose, if you got better on it, that's the dose you should stay on. So maybe Falk got better with a smaller dose of an antidepressant.
Maybe it also says something on human beings. People are, as you mentioned, the barriers towards effective antidepressant or psychotherapy is patients are afraid of becoming dependent. But a lot of patients want to continue a little bit with a small dose just to feel safe. And so this fear of addiction on the one hand, and then not willing to stop to feel secure. And the same is true because fear of becoming dependent is true with pharmacotherapy, but the work from Matthias Angermayer in Germany was also that patients are sometimes against psychotherapy, also the fear of becoming dependent upon the therapist. And so this is human beings, I think. How long would you treat a patient with a first episode of depression?
Well, I need to find the medicine that works first, and so the time it takes to get well is variable from person to person, but once you've declared victory that the person is well or nearly well, you have a figurative clock running that you want to go at least 4 to 6 months in that state of well-being to prevent early relapse. And then you make individualized decisions past those 6 months. If it's a first lifetime episode and the individual is not at high risk in any other way, you may taper and fade off the antidepressant and follow with watchful waiting for some amount of time. If the individual has risk factors for recurrence, or they're in the middle of a divorce or a bankruptcy or some other potentially catastrophic life event, you may go longer simply because bad events do increase the risk of relapse the same way they increase the risk of onset of a first lifetime episode.
Yeah, I think we have data up to 3 years. If you look at Cipriani's paper, in fact, during the first year, if you continue, you have a 70% reduction of the risk of relapse. Second year, again 70%, and the third year, again 70%. But of course, your baseline risk goes down. So is it worthwhile the third year for 5% being better protected to continue for 1 year?
So in our studies at the University of Pittsburgh, we had 3 different times of time on therapy, and the hazard for recurrent depression was equally harsh whether you had a short course of treatment, an 18-month course of treatment, or even a 3-year course of treatment. But this is recurrent depression, not first episode depression.
So now I have a very difficult, challenging question for all of you. So you don't think, or do you think, that the dissociative experience is necessary for NMDA-associated antidepressant effects? Who dares to answer that question?
In both the original observations with intravenous ketamine and in the Janssen database for S-ketamine, there is a trivial, non-important correlation between the intensity of the dissociative experience and the likelihood of therapeutic benefit. And by trivial, I can tell you the number in the Janssen data set is on the order of 0.2. This is not a meaningful predictive association, and it may simply reflect drug exposure. So unlike what we're seeing with psychedelics, with ketamine and S-ketamine, you do not need to see the walls warble or to see fancy colors, have God touch your soul to have an antidepressant effect. I tell my patients when they have a powerful experience that they got a lot of drug, and when they don't have a powerful experience, I'll say, you're lucky you didn't have an unpleasant experience. It doesn't influence your chance of success.
Okay.
Yeah.
Sarah is looking as she also wants to say something on this.
I may want to play devil's advocate here, Professor Thase, and maybe point towards a recent study from Stanford where ketamine was administered in the context of general anesthesia, and it did not perform. Placebo performed very well, we should say, but there was no difference between ketamine and placebo. Right, so could this speaking also to the importance of the dissociative experience, in your opinion?
I'll trust the experience in head-to-head randomized studies in depressed patients as opposed to an anecdotal observation done by a group that's had some number of provocative findings.
I think overall, it's still a very big open question in the field, in my opinion, in terms of like dissociative experience. Most certainly, as Professor Thase pointed out, it is a measure that the drug gets into the brain, for sure. But in terms of the intensity and the quality of this dissociative experience, is that really needed? I think we need to know more about that.
Yeah, I agree with what Michael said, that in the Janssen database, the correlation is low. Yeah. The question one has to ask is, of course, also is the scale or the assessment of dissociation really picks up what's happening? That's another question, I think.
Well, in the studies, they checked dissociation in different ways, right? It was patient-reported, and then we also had the scales. And again, there wasn't proof that dissociation correlated with success, but you saw it as a very common, like in the J&J study, it was like 60 to 80% of the patients did experience dissociation, so it is high.
But definitely dissociation is something that can limit the use of the drugs, right? So if we think of a patient with psychotic depression, for example, or bipolar, is something that we are all a bit cautious with because of this dissociative effects. So I think it's something that we'll see in the future how it pans out.
Yeah. Another question is, how does altering the synaptic density contribute to the effectiveness of antidepressant treatments? Left, right? You can answer.
I think it talks about the function of the neuron. I mean, Laura pointed out it's something that we didn't even expect to be possible, right? We think, well, neuron dies and and that's it, you have to deal with it. But it's actually, there is a possibility of growth, and there is implication in terms of the function of neuron as a downstream effect, that it goes hand in hand with these synaptoplasticity.
There are autopsy data that really indicate that people who have had poorly treated chronic or highly recurrent depression just show less rich connectivity in critical regions of the brain. Severe, recurrent, poorly treated depression really does cause changes in, and I assume synaptic density here is a reflection of the arboreal connectivity between the different regions, and depression adversely. I don't know this from my own research. I just read and look at the pictures and such the same way that you do. But it's a fairly compelling story that the decrease in quality of life that our patients live in is accompanied by a decrease in the richness of the central nervous system connectivity.
So I liked very much, Lara, that in the development plan of the new drug, that they are going as well for monotherapy as for what you called adjunctive therapy. I would say it's not adjunctive, I would say it's concurrent, because it's probably, hopefully, also being an antidepressant on its own.
I think the FDA likes
because
to call
adjunctive
it
means like the adjunct is just the minor one.
Right.
And hopefully this is going to be a major one. So I would say it's concurrent. But it brings me to a question. How do you think that our expectations and strategies for the treatment of depression will evolve now that rapid-acting treatment options are available? What will be the place of existing antidepressant therapies in the future?
I think they're still going to be there, right? The current treatments we have there are being used just as they have been, but the rapid acting are really going to serve its nice place in patients, for example, with more acute symptoms, maybe even suicidal ideation. Obviously, we have one of the glutamate compounds on the market, FDA approved recently, for major depressive disorder with depression with suicidal ideation. Because in the United States system, when we have a patient who's suicidal, we might put them on a hold against their will, take them to the hospital, but what are we really doing for them at the hospital? There's nothing we can really do besides babysit them and start them on an antidepressant and hope for the best and discharge them after a few days, because that's all insurance will cover. So we don't have success with our current treatment modalities where we could say we've seen an improvement in the first 8 days. But if you have someone who needs a quick turnaround, right? It's life or death at this point when we're talking about a suicidal patient. 8 days versus 6 weeks, 8 weeks, that's a huge difference. And with the suicide rates increasing the way they are across the world, right? Especially in certain populations, there's no reason why we shouldn't be looking at faster options. The other ones will still be present, they won't be taken off the market, but especially if the side effect profile is more tolerable, patients want responses more quickly. They're losing faith with these long-term options.
So if English is not your first language, the old term augment and the new term adjunct have quite different meanings. To augment something means to enhance it, and so there's the misbelief that the new treatment that's added to the old treatment is actually somehow making the old treatment work. And that's mostly not the case. For most, the new treatment is simply being added on top of a platform of a hopefully well-tolerated but not effective old treatment. So it's not actually making the old treatment work. It's simply being used for quickness' sake to help the patient get better quicker. You should be done with that old treatment if possible. Once the patient is better, there's no need to be on 2 medications when it's clearly the newer medication that has made the difference.
Yeah, I'm not native English speaking, but the same is true, for example, for the word combination treatment. We say we combine 2 antidepressants. That's not combination treatment. In other fields of medicine, combination is 2 drugs in 1 pill. And that is not the case for most of the things we do. Okay, anyhow, time is up. We are finishing. Try to fill out the evaluation forms, because that is very important for us for future programs. Please give us your suggestions. First of all, I want to thank the speakers. I think we saw very different presentation styles, and to be honest, I enjoyed all of them. I think it was really stimulating, the different presentations. I also want to thank Nucleus Global for all the help we had in putting all this together.